This conference will now be recorded.
Hello. Hello, everybody. How are you? Okay. Today your class is on malpresentations and malpositions. So one of the malpresentations you have heard last week, that is breech presentation. So when do you say malpresentation? Whenever the baby is presenting by any other pole other than the vertex. You call it as abnormal presentation or a malpresentation. Malposition is, so I hope you all know the definitions of lie. You should know the definition of presentation. You should know the definition of position and attitude. All these four definitions, all of you should know. So malpresentation is any other presentation other than the vertex, normal vertex presentation. Malposition is in a vertex presentation, the commonest position is a left occipital transverse. So any other position other than the left occipital transverse is known as a malposition. Okay. So most common malposition is occipital posterior positions. Right occipital posterior is the most common presentation, malposition. Whereas when it comes to malpresentations, other than the vertex, the malpresentation is most commonly it's a breech presentation, right? So 99.99.5% of the cases, it will be a longitudinal lie, right? In that, around 96 to 97 will be cephalic presentations, and only 2 to 3% are breech, whereas a transverse or an oblique lie are hardly 0.5%, right? In that 96 to 97% of the cephalic presentations, more than 99% will be again vertex presentations. Only half and half percentages will be breathe, brow and face presentation, depending upon the amount of flexion, deflection, extension. So under cephalic presentations, you get a vertex presentation if it is a well flexed head. If it is a fully extended head, you get a face presentation. If it is in between, you will get a brow presentation. So out of the 97% of the cases, only half and half are brow and face. All the rest are vertex presentations, right? So the most common presentation is always a vertex presentation, and occipital anterior will be the position. Okay, so these are the malpresentation. So here there is a deflexed attitude of the head. Both inciput and occiput are at the same level, right? The back of the baby is on the left side. It is a deflexed attitude. So this can turn either into, it can extend and then it can become the face presentation, or it can extend a little bit and become a brow presentation. So this is the occipital posterior position. See, look at the back of the baby. It is posteriorly placed. Occiput is posteriorly placed, right? So this is the left occipital posterior. This is the right occipital posterior. These two are occipital posterior positions. This is a sinciput and occiput are at the same level. This is a deflexed head, which you commonly see in this occipital posterior positions, and this is an extended head, face presentation. So these are malpositions. This is malpresentation, right? Okay. So why do you think the baby presents? What are the general causes for any malpresentation or malpositions? So it's a dystocia. So dystocia can be in the power, in the passage, or in the passenger. 3 P's are required. Now another 4 P's also has been added to this. That is the psyche of the lady who is in labor. So the patient should be she should be educated properly about the labor, its consequences, duration of labor, and all those things. So psyche of the patient is also very, very important. Her attitude towards labor is very important. She should be able to withstand the pain of the uterine contractions. Okay. So the causes of malpresentations can be divided, malpresentation or position can be divided into defect in the abnormalities in the power, passage, and passenger. Power means uterine. uterine action. So you have a grand multiparous women, it's a fifth gravida, sixth gravida, who are fortunately uncommon nowadays. So you have a grand multiparous lady who has a very pendulous abdomen, laxity of the abdominal muscles. So in such cases, malpresentations and positions are very, very common. And the dextrorotation of the uterus, marked dextrorotation of the uterus can also lead to malpresentation sometimes. Okay. And rotation of the uterus anti-clockwise direction favors an occipital posterior position in the right side rather than an occipital anterior positions. Then in the passage, contracted pelvis, android, anthropoid pelvis. So it's not written here. But remember, abnormal pelvises like android and anthropoid pelvises, they usually favor malpositions and malpresentations. So likewise, pelvic tumors or ovarian tumors which are impacted in the pelvis, they also will cause malpresentations. Then uterine anomalies, that is bicornuate uterus, septate uterus, fibroids uterus, all those things can also cause septate, subseptate, unicornuate uterus, bicornuate uterus, all those congenital uterine anomalies due to Mullerian defects. They also will cause malpresentations. Then placenta previa can also cause malpresentations like breech. Then defects in the fetus, congenital abnormalities, large babies, multiple pregnancies, polyhydramnios. So some are not mentioned here, but just remember that multiple pregnancy, anomalous babies like supposing anencephaly usually presents as phased because it has no vertex. Usually the presentation will be a phase presentation. Hydrocephalus will present as a breech presentation. Okay. A large macrosomic baby will have a deflexed attitude and may present as occipital posterior positions, or it may present as brew and other ones. Polyhydramnias. Okay. Right. So these are some of the causes for abnormal presentations and malpositions. Okay. Now let us go to the commonest malposition, that is occipital posterior positions. So when do you say occipital posterior positions? When the occiput is in relation to the posterior quadrant of the pelvis. What do you mean by position? When the denominator is in. So for every presentation we have a bony prominence which you have arbitrarily chosen, which is known as a denominator. So the relation of that denominator in to the quadrants of the maternal pelvis is known as position, right? So for vertex presentations, we have taken occiput as a denominator. Okay. For face, we have taken mentum as a denominator. For a brow, we have taken frontal bone as the denominator. So likewise, for breech, we have taken sacrum. For shoulder, we have taken the acromion, right? So in occipital posterior positions, what is the denominator? Because it is vertex, it is occipital. So the occiput, when it is in relation to the posterior quadrants of the pelvis, it is called occipital posterior. Normally it is anterior. Here it is posterior, as you have seen in this diagram. See, the occiput is in relation to the posterior quadrants of the pelvis, either on the right side or on the left side. ROP is more common when compared to LOP. Okay. And the incidence is, now as we have already learned, more than 80% of them present as occipital anterior positions. Only 20% of the cases you see occipital posterior positions. Again, this can be primary or it can be secondary. Primary means when it is present before the onset of labor. Any malpresentation, any malposition, if it is present before the onset of labor, you call it as a primary malpresentation. Primary phase, primary brow, or something like that. Or if it presents after the onset of labor, you call it as a secondary malposition or malpresentation. So the incidence of occipital posterior position is roughly around 20%. 80% of the vertex presentations are occipital anterior, LOT or LOA. So ROP is more common than LOP because of the presence of the sacrum discourages the right occipital posterior positions. discourages left occipital posterior positions. Then it is an abnormal position but not presentation, right? Then cause is, rather than the android pelvis, it is the anthropoid pelvis which may be responsible for occipital posterior position, because there is a transverse narrowing of the mid pelvis. Same thing is with the anthropoid pelvis also, where it has more AP diameter rather than the transverse diameter. So abnormal shape of the pelvis is the most important cause for an occipital posterior position. So how do you diagnose occipital posterior positions? For abdominal examination, you find that there is subumbilical flattening will be there because the back is posterior. All the limb buds are felt very easily. They are in the midline. You will not be able to feel the back very easily. It is more towards the flank, and it is difficult to identify the back. And then the vertex presentation it is, but there is a delay in engagement because engaging diameter is, instead of the suboccipito-bregmatic diameter, which is a usual diameter in the vertex anterior positions, here it is because of deflection and the head is not well flexed. So you have either suboccipito frontal or occipito-frontal, 10.5, 11.5. So subumbilical flattening, limb buds are felt very easily in the midline, back is difficultly felt in the flank, the head is engaged very late, then the anterior shoulder lies far away from the midline, and fetal heart sounds are heard with difficulty. They are best heard in the flanks, right? So these are the abdominal examination findings. So whenever you find back is on the right side, always we have to suspect an occipito-posterior positions. So when you are examining, doing a umbilical grip. So the purpose of the umbilical grip is to know which side is the back and which side of the limb buds. So if you find back on the right side of the patient, you have to suspect an occipito-posterior positions. So now that we have ultrasound, it's very easy to diagnose an occipito-posterior. Otherwise, previously when we never had an ultrasound, particularly in the labor room, we had, but it used to be in the OP. We never had ultrasounds in labor. So intrapartum sonography is very, very useful to identify malpresentations and malpositions. Right. Pelvic examination. So pelvic examination, you find head high up in the pelvis because engagement is very delayed. Descent is also very delayed because of the larger diameter. The sagittal suture is occupying the right oblique diameters. Then posterior fontanelle will be felt near the sacroiliac joint. Anterior fontanelle will be easily felt because of the deflexed attitude. Normally you feel in a well flexed head, you will feel only the posterior fontanelle anteriorly. We will not be able to feel the anterior fontanelle. But here, because of the deflexed attitude, anterior fontanelle can be easily felt. Then premature rupture of membranes. And if membranes are present, they are not well applied. They are loosely hanging. So early rupture or premature rupture, then there may be cord prolapse, all those problems will be there, right? So in an occipito anterior, you will be able to feel it's a well flexed head. So you will be able to feel only the posterior fontanelle, but here you will be able to feel both posterior as well as the anterior fontanelles. And you find that the posterior fontanelle is placed posteriorly. Then the mechanism of labor in a persistent occipito posterior. So if the most of the cases, these occipito posterior positions, they get corrected once the woman goes into labor. They get corrected. So usually the labor is prolonged in these cases. The engaging diameter either suboccipitofrontal or occipitofrontal, that is 10.5 or 11.5. So with each increasing uterine contraction, head descends until it reaches the pelvic floor, that is at the level of the ischial spines. So if the circumstances are favorable, right, most of the times it undergoes a long internal rotation, right? From the posterior, it has to become transverse. From the transverse position, it has to become anterior. So it undergoes long internal rotation of 135 degrees, 90 plus another 45 degrees. So what do you mean by favorable circumstances? It's an average sized baby, right? Not a large baby, okay? Then the most important factor is the pelvis should be a good gynecoid pelvis. Then uterine contraction should be good. This average size of the baby, right? So when when the circumstances are very favorable like this, 80% of the cases, long forward internal rotation will occur. The so-called occipito-posterior will become occipito-anterior, and then the normal labor will occur. In unfavorable circumstances, that is, so what are favorable circumstances? Good gynecoid pelvis, average size, good uterine contractions, rupture of the membranes. Of course, this may be a premature rupture of membranes. We don't wait till full cervical dilatation most of these cases, because of prolonged labor, sometimes we suspect fetal distress. So you would like to do an artificial rupture of membrane to see whether there is any meconium staining. And also the purpose is to accelerate labor. And then the most important is a good pelvic floor tone, because the internal rotation is mainly the function of the levator ani. So the patient should have a good pelvic floor muscles. So pelvis, average size baby, good uterine contraction, good pelvic floor, right? So in all these cases, the head will descend up to the pelvic floor and rotates 3/8 of a circle or 135 degrees. Takes a long internal rotation. Okay. So the whole thing will take a long internal rotation to become anterior, and then delivery will occur as in normal vertex anterior positions. Okay. In unfavorable positions like juxta opposite of it, android pelvises, anthropoid pelvises, converging side wall. These are all the characteristic features of android pelvis. Straight sacrum, converging side walls, or an anthropoid pelvis with a large AP diameters. In such cases, forward internal rotation will not occur. Large babies, premature rupture, uterine contractions are not weak, or the pelvic floor is very poor because of previous injuries or grand multis. In such cases, forward rotation fails to occur. Then what happens? It remains as occipito-posterior and delivers as a persistent occipito-posterior. This is what is known as a face to pubis deliveries. So persistent occipito-posterior, it descends down in the posterior position itself, because there is no space for the baby to turn. Either maybe the pelvis is not adequate, or the baby is large, or the pelvis is not, pelvic floor is not of good tone. In such cases, it remains as occipito-posterior till the full dilatation of the cervix. Even after that, that is known as a persistent occipito-posterior position, and it may deliver as face to pubis deliveries. These are the deliveries which are referred to as face to pubis deliveries. Then sometimes the rotation will occur only for through 45 degrees. So from the posterior, it comes up to the transverse diameter, and then it gets arrested. It cannot further rotate anteriorly because there is no space. Let us say that the outlet is very narrow subpubic arch, narrow subpubic angle. The waist space of Morris is more. So beaking of the fore pelvis. In such cases, there is no place for the baby to turn to the forward diameter, and so it gets arrested in the transverse diameter, which is referred to as a deep transverse arrest. So the name itself suggests that the head is arrested in the transverse diameter, and then it is deep in the pelvis. That means where does the internal rotation occur? It occurs at the level of the spines. So that is deep in the pelvis. So deep transverse arrest is the term which is used when after full cervical dilatation, in spite of good uterine contractions, right? 1 to 2 hours after full cervical dilatation, in spite of good uterine contractions, there is no progress of labor. There is no descent to the fetal head. There is no rotation of the fetal head. It is arrested at the level of the spines or just below the level of the spine. That is called deep in the pelvis, with the sagittal suture occupying the transverse diameter of the cavity of the pelvis. That is referred to as a deep transverse arrest, which usually results in obstructed labor. And the mechanism of delivery nowadays in modern obstetrics So previously they used to do what are known as vacuum deliveries, or you have special types of forceps deliveries. So either a manual rotation or a forceps rotation or a vacuum delivery is used to be done for these deep transverse arrest cases, but it causes lots of injury to the mother as well as to the baby. That's the reason why nowadays modern obstetrics, deep transverse arrest, always better to deliver by a C-section. Then very, very rarely, other type of mechanism of action for occipital posterior is, in a case of an anthropoid pelvis, because the AP diameters are large. So instead of taking long internal rotation, okay, so here it is the occiput, right? This is the pubic symphysis, and this is the occiput. So most of the times, if it is favorable, the occiput takes a long internal rotation. So first it becomes transverse, then it goes anteriorly, right? This is 45 plus another 90 degrees. It takes a 130 degrees rotation. This happens in favorable condition. That means the baby is average sized, the uterine actions contractions are very good, the pelvic floor is very good, right? And the pelvis is a good gynecoid pelvis. You see, it's a wide one. Look at the inlet, it is a wide one. Okay, it's a good gynecoid pelvis. So in cases where this space is not sufficient for the baby, it takes a 45 degrees rotation and gets arrested in the transverse diameter. There is no place. So this is convergent like this. Okay, when the side walls of the pelvis are convergent, the baby doesn't find place to rotate forward. So it gets arrested in the transverse diameter at the level of the spines or just below the level of the spines, even after 1 to 2 hours of full cervical dilatation and despite adequate uterine contractions. So this is known as a deep transverse arrest. So from here, it has gone only 45 degrees. If it had taken another 90 degrees, it would have come anteriorly, but there is no space because of converging side walls. It may be an android pelvis or it may be an anthropoid pelvis where the transverse diameters are very narrow when compared to the AP diameters, right? So favorable, everything is favorable, particularly the pelvis, pelvic floor tone, and the average size baby, a long internal rotation to anterior and delivers normally. Unfavorable conditions, either there is deep transverse arrest because it takes only 45 degrees rotation and gets arrested, or it remains like that, persistent occipito-posterior position. This is the one which may deliver as face to pubis deliveries, right? So face to pubis deliveries are associated with considerable trauma to the mother. Particularly these deliveries are supposed to be associated with perineal tears because the hard part of the occiput is coming against the anal canal. So normally when it is fully rotated, the face is coming down, which is a soft part. Whereas here, it is the occiput which is coming against the anum and the rectal canal, anus and the rectal canal, anal canal and the rectal canal. So the deep perineal injuries, third degree perineal tears, complete perineal tear, they're all very common with the face to pubis deliveries. Okay. Next. So this is an anthropoid pelvis where the AP diameters are very long. In such cases, instead of taking a long internal rotation to the anterior, the baby finds it easy to take a reverse rotation and go into the sacral hollow. This is known as an occipito-sacral position, right? This can happen only in anthropoid pelvis where the transverse diameters are less and AP diameters are more. So instead of going all the way 3/4 of a circle to the anterior, the baby finds it easy to go back into the sacral hollow, only 45 degrees. So this is referred to as an occipito-sacral position, right? So this is also again face to pubis deliveries. So So more than 80% of the cases, given the favorable conditions, long internal rotation on 3/8 of a circle or 135 degrees, it turns anterior and then the rest of the labor is normal. In an android pelvis or an anthropoid pelvis, mostly an android pelvis with a convergent side walls, the baby turns only 45 degrees and gets arrested in the transverse diameter, which is referred to as deep transverse arrest. Then sometimes there is no place to rotate even transversely also. The walls are so convergent that it cannot take even a 45 degrees and remains like that in the oblique diameter, which is referred to as a persistent occipito-posterior positions, which may deliver as face to pubis deliveries, which are associated with complete perineal tears because the hard part of the skull is coming against the rectum and the anal canal. Then in anthropoid type of pelvises, because the AP diameter is long compared to the transverse diameter, the baby finds it easy to go into the sacral hollow, reverse rotation. 1/8 through 1/8 of a circle or a 45-degree circle and goes into the sacral hollow, which is referred to as occipitosacral position, which again delivers as face to pubis delivery. So this is the mechanism of labor in a case of occipito-posterior positions, right? So possibilities of deliveries on occipito-posterior position, spontaneous deliveries, forceps deliveries, and ventose deliveries. So spontaneous deliveries is into the reverse rotation. This I've already told. The reverse rotation into the sacral hollow known as occipitosacral position and then delivers as face to pubis deliveries. Okay, the sinciput will reach the pelvic floor first because of marked deflection. Then the occiput will rotate back towards the sacrum. The head is delivered initially by flexion, but extensive perineal lacerations will be there. Complete perineal tears are common. So this is too small for you. The same thing is given in a flow chart, right? Engaging diameter, all this I have already told you. Either suboccipitofrontal 10 and occipitofrontal 11.5. So everything is favorable. It will descend and deliver normally. Unfavorable conditions, it gets either deep transverse arrest or oblique posteriorly, persistent occipito-posterior and occipitosacral. So these two can deliver as face to pubis deliveries. Okay. Now, so forceps deliveries, occipito-posterior, low in the pelvis, and you can deliver it with a forceps. Liberal episiotomy may be needed in these cases. Ventose can also be used, and cesarean section is usually performed in cases of arrest of the fetal head anywhere, either at the brim or in the inlet. If the arrest is at the cavity, then you may be able to put either a forceps or a vacuum. But if the arrest is somewhere high up, you will not be able to do an assisted vaginal delivery. So safe for the baby is always a cesarean section. When the labor is getting prolonged, there is rupture of membranes, the caput formation is there, which makes very difficult for you to follow the progress of labor, whether the head is rotating or not in presence of caput succedaneum. So in such cases, it is always better to go for an abdominal delivery. Okay, the same thing. Okay, so that is about occipito-posterior positions, and then I didn't tell you anything about manual rotations and forceps rotations and the vacuum deliveries because we are not doing such things now because they are highly traumatic to the mother as well as to the baby. So previously they used to do manual rotations as well as forceps rotations, and special types of forces were designed for occipito-posterior positions, that is Keeland's forceps. So I'm not telling you all those things because it is now, they have no role in modern obstetrics nowadays, right? Because 80% of them will deliver after turning normally. Only those 20% of the cases where they either go into deep transverse arrest or into a persistent posterior or occipitosacral. If you think there is delay in labor and then the baby is forming the caput succedaneum, evidence of fetal distress, maternal distress, all those things, better to go for abdominal delivery. Then next comes the face presentation. So already we have already told among the 97% of cephalic presentations, face presentation is only 0.5, right? So definition is where the head is completely extended. So it is completely extended. It is known as a face presentation, where the occiput is in contact with the fetal back of the baby. The presenting part is usually the chin. That's why we have taken mentum as the denominator. Chin, mentum. So the incidence is very, very rare, 0.5%. Right? Okay, so if you do a pelvic examination, you should be able to make out the chin of the baby. You should be able to make out the mouth, and then the nostrils, then the nose of the baby, eyes. Okay, then you call it as a face presentation. Okay, so the engaging diameter is submentobrachmatic diameter, which is the same as that of the vertex presentation, suboccipitobrachmatic. Here also you have a submentobrachmatic. It is the same thing, right? So etiology, it is the same for all malpresentations. So primary face presentation, I've already before the onset of labor. This is less common, mostly due to fetal causes, like anencephaly, I've already told you. Because in anencephaly, already the head has nothing except face. There's no vault at all. So most of it presents as face, but usually there will not be any problem here. And since nowadays, because of the routine TIFA scanning, we are able to diagnose anencephaly. We don't allow, these babies are not viable babies. So we don't allow them to go up to the term and then deliver them, right? So most of them are diagnosed in the TIFA scans and most of them are terminated. Then anything which prevents flexion of the fetal head, like cords, loops of the cords around the neck, or any congenital tumors of the fetal neck, either congenital coitus, cystic hygromas, all those things. Or sometimes sternomastoid muscles, hypertonicity of the extensor muscles of the neck, which don't allow the neck to flex properly. Then dolichocephaly is where the epidiameter is long, then whereas the transverse diameter is less. In such heads also, flexion will not occur. Or a dead or a preterm baby, and maybe idiopathic or polyhydramnios and other ones. Especially you have to think of in-face presentation, other than the common causes which we have discussed in the early part of the class. You have to remember those abnormalities which prevent the flexion of the fetal neck, like cord around the neck or tumors of the fetal neck, congenital coitus, all those things. So secondary face presentations are more common, which occur during labor because of either contracted pelvis, pendulous abdomen, marked dextrorotation, lateral obliquity of the uterus. Then whenever there is a deflexed head, supposing it's a bro presentation or occipito-posterior positions, when the uterus starts contracting, then the baby may go in for a secondary face presentations. So bro presentations are usually unstable presentations. Once the uterus starts contracting, most of the bro presentation, they get converted either into a face presentations. They extend completely and become face, or they flex completely and then the occipito-posterior positions will come. Other causes of malpresentations are the same, like polyhydramnios, placenta previa, CPD, other things. So diagnosis of face presentation, most important thing is when you examine the patient, you find that the occiput is on the same side, the cephalic prominence, that is, the occiput is on the same side as that of the back, right? Instead of the side of the small parts in vertex presentations. But normally occiput you will feel on the opposite side of the back. Whereas here you will see, because of extension, you will find back and occiput are on the same side. And sometimes you can even feel the groove in between the two. And the back is distinctly felt only near the breech. Fetal heart is best heard around the umbilicus. pelvic examination, if the patient is in labor, normally if the cervix is closed, it's difficult to make out. Only when the woman goes into labor, when the cervix is dilated, then when you do a pelvic examination, you will be able to make out the mouth, the nose, the malar eminences and orbital ridges. And sometimes these soft parts may be mistaken for breech. So this I have already told you. In case of face presentations, the malar eminences and the mouth, they form a triangle, whereas in breech, the ischial tuberosities, they lie in line with the anal orifice, and then the sphincter activity, as well as in the mouth. If the membranes are ruptured and you put a you can put a finger either into the anal canal or into the mouth, and you can make out whether it is face or breech. And confirmation nowadays is always by ultrasound. And on ultrasound, you find that the head is completely an extended head. So what are the positions? Again, the denominator I have already told you. Mentum is the diameter. Position, the relationship of the mentum to the quadrants of the maternal pelvis. The most common is a right mentor posterior, then left mentor posterior, left mentor anterior, right mentor anterior. These are the common positions. In the same way, wherever the mentum is pointing, a posterior or anterior, left side or right side, depending on that, you have all the positions. Same as in occipital posterior patients. So palpation, you can find. So if you are doing a palpation, you can find on the same side as that of the back, you can find the occiput of the baby. All right. And cephalic prominence will be at a lower level than that of the occiput. Okay. Of course, it is difficult to make out mento anterior or mento posterior, but you can only make out that it is a face presentation. So only when you do a pelvic examination, we can make out whether it is a mento posterior or whether it is a mento anterior. Right. So here mento anterior, here it is posterior. This is difficult to make out in abdominal palpation. Only when the cervix is dilated and you start examining, then you can make out that in this case, and if the mentum is anteriorly, you call it as an mento anterior positions. If mentum is posterior, you call it as mento posterior positions. So mechanism of labor is same as in vertex presentations. So chin is like occiput. So movements are descent with increasing extension. So there you have descent with increasing flexion, is it not? Because here the head is already extended, it descends with increasing extension only, right? Then there will be internal rotation of the chin. The chin touches underneath the symphysis pubis, and then it is borne by flexion. Whereas in a vertex presentation, because it is already well flexed head, is it not? Vertex is a well flexed head, so it has to come out of the birth canal. It has to come out of the vulval outlet only by extension. Whereas here the face is already extended, so it can only come out of the birth canal by flexion. So these are the only differences. So engagement and then descent with increasing extension instead of flexion, internal rotation, and head is borne by flexion. Then again restitution, external rotation. Everything is the same. Okay. So beginning of the labor, the head is high up, therefore not in complete extension. So as the baby is descending down, it undergoes more and more of extension. చెప్పేసాం కదమ్మా ఇదంతా labor descent with the extension, then submentobregmatic diameter same 9.5, meets the pelvic floor, anterior rotation, it brings underneath the symphysis pubis, delivered by flexion, restitution, external rotation, and rest of the body. So there's no problem because the diameter of engagement is the same. There you have suboccipitobregmatic, here you have submentobregmatic. There is complete flexion, here it is complete extension. But only the problem is, here it is the soft parts which are meeting the pelvic girdle. Is it not? So these soft parts, they become very edematous, they become congested. eyes are swollen, lips are swollen, cheeks are swollen. They all add to the presenting part. Volume, so the volume of the presenting part which has to come out will be increased. Right? That's why there will be difficulty in labor, not because of large diameter, but because the soft tissue edema and congestion. So the whole face of the baby will be very much congested and swollen. So these babies after birth, they will have difficulties in sucking also because of edematous lips. Okay. So that is the reason why there is a difficulty in delivery. Prolonged labors and all are common because the soft tissue is adding to the amount of the baby that has to come out. Right. So this is the submental bregmatic diameter. Here it is not completely flexed. Right. This is a bro presentation. No complete, extension. So as it is coming down and down, it undergoes more and more of extension. Right. So this is the mento anterior. Okay, pubic symphysis, chin is mento anterior. It is easy to deliver. Right. So supposing it is mento posterior. If it is a mento posterior, here also, just like an occipito posterior position, it also undergoes a long internal rotation to become anterior and then delivers as in a mento anterior position. Right. But persistent mento posterior or reversal of rotation into the sacral hollow, there is no normal mechanism of labor for this persistent mento posterior position. So just like how you have a face to pubis deliveries in a persistent occipito posterior and in occipito sacral positions, is it not? There the baby delivers as face to pubis, whereas such a mechanism is not there for persistent mento posterior. If it rotates as anterior, okay, it delivers as an anterior position. But if it remains like that, no rotation, persistent mento posterior, or it has rotated to the sacral hollow, reversal of rotation, that is direct occipito posterior. So in such cases, there is no normal mechanism of labor for this and leads usually to arrest of labor, later on to prolonged labors, arrest of labor, then obstructed labor, and maybe rupture of the uterus. So one of the causes for rupture of uterus are deep transverse arrest. Likewise, deep transverse arrest also there is no normal mechanism of labor. Persistent mento posterior also there is no normal mechanism of labor. Then bro presentation, there is no normal mechanism of labor. So these are some of the malpresentations and position. They don't have a normal mechanism of labor. So usually they go into obstructed labor. So whenever you are asked to write about the causes for obstructed labor, there also again you have to take passenger, passage, power and so on. So when you are taking the passenger, you have to write about malpresentations and malpositions other than other abnormalities and congenital anomalies, hydrocephalus and so on. So in that you have to write all these malpositions, right? Deep transverse arrest, persistent occipito posterior where delivery is not possible as face to pubis, persistent mento posterior, right? Where there is no normal mechanism, bro presentation where there is no normal mechanism, shoulder presentation, no normal mechanism. So these are all the malpresentations and positions for normal delivery. So this is how mento anterior is delivering by flexion. See how the baby is coming out? It is coming out by flexion. Okay. So the whole thing will become very much edematous. It will not be able to open its eyes. It will not be able to suck. Okay. Right. Okay. This is mento posterior. See. This is the sacrum, this is the pubis. So you see, where is the mentum? It is posteriorly. So there is no normal mechanism of labor for mento posterior. Only thing is, it has to take a long internal rotation to become anterior and deliver as mento anterior. If it remains like this, it cannot be delivered. and leads to obstructed labor. Then comes the bro. Bro presentation is midway between flexion and extension, because there is a partial extension of the head, a little bit of extension, not complete extension. So in such cases, if you do a PV, you will be able to make out only the brow of the baby. You can't make out the chin and the mouth. Okay. Even the nostrils also you can't make out, even if it is fully dilated, which usually doesn't happen because there is no normal mechanism of labor for persistent brow presentation. Again, I have already told you it is an unstable presentation. Brow is always, right? Usually either it completely extends. So this baby won't remain like this. Once the uterus starts acting, so uterine action can do wonders. And nothing in the nature can mimic uterine action. Even if you use oxytocin, use prostaglandins, nothing can mimic a normal spontaneous uterine action. So this brow, it completely extends and then it becomes a phase, or it completely flexes and it becomes a vertex presentation, right? Okay, so it is an unstable presentation. If it remains like this without getting either flexed or extended, you call it as a persistent brow presentation. So this is normal mechanism of labor is not possible because the diameter of engagement is the largest diameter, that is vertigo-mental diameter, that is from the chin to the highest point on the vertex, which is around 13.5 centimeters or even 14. So there is no pelvic diameter in the pelvis which can allow this large diameter to pass through. So persistent brow presentation, particularly in multigravida, usually goes unrecognized. Right? We are always worried about the primates because we don't know whether that particular pelvis will allow this baby or not. But it so happens that in multis with a good obstetric record, they have delivered twice, thrice, 4 times, 5 times before. In such cases, we tend to neglect, particularly the ANMs or ASHA workers when they are conducting deliveries. They take very light because it is a head. When they examine per abdomen, they feel the head only, right? And even when they do a PV also, they feel only the head. So that they are not so vigilant enough to look for the orbital margins, then the tip of the, not the tip, root of the nose and other things. So just do a PV, they find this head, okay, it is head cephalic presentation, vertex presentation, you can proceed. So this is unrecognized brow presentations, persistent brow presentations with the largest engaging diameters of all the presentations, vertigo-mental, that means from the chin to the highest point on the vertex, that is 13.5 to 14, which normal mechanism of labor is not there. So unrecognized persistent brow presentations are the most common cause for obstructed labor and rupture uterus, particularly in multis. Okay. So this is most unfavorable presentation. All right. So we have taken position anterior fontanelle, frontal bone actually. Okay, it's not fontanelle, frontal bone. So that is the position. So we have fronto anterior, fronto posterior, all those things. But anyway, position doesn't matter because brow usually doesn't remain like that. It becomes a vertex by flexion or phase by extension. Persistent brow presentation is the most common cause for obstructed labor, rupture uterus, undiagnosed persistent brow. Right, so during pregnancy, it is difficult to diagnose. Occiput, inciput may be felt at the same level. Ultrasound is nowadays more useful to detect all these malpositions and presentations. So during labor, vaginal examination will you will be able to make out the brow, that is the frontal bone, then the supraorbital ridges and the root of the nose. But you will not be able to make out the chin. Right? If you can make out the chin of the baby, the nostrils, mouth, then it becomes a face presentation. So whereas in a brow, you will feel only the brow. Brow, the supraorbital ridges, frontal bones, and the root of the nose. That's all. Right? So you can't make out anything else. Okay. So no normal mechanism of labor because there's so much of diameter. See, such a big diameter. So there is no pelvic diameter which can allow. Due to instability, convert into phase and vertex. If it persists, the progress is arrested because the engaging diameter is mentovertical 13.5. Right? So in 30 to 40% of the cases, it converts to phase or vertex and spontaneous delivery can occur. But remaining, where rotation, where the change has not occurred, you have to do a cesarean section, otherwise obstructed labor and rupture uterus. So management early in the first stage, exclude contracted pelvis, and if CPD is present, do a cesarean section. If it is a transient presentation, observe the mother carefully and give a chance. Keep watching the progress of labor and see whether spontaneous conversion can occur into either phase or vertex. Second stage is usually a persistent presentation, so always do a C-section. So if the patient has come late in labor with evidence of obstructed labor, then also modern obstetrics, better to do a C-section in the interest of the baby, even though in the interest of the mother, even though the baby is not living. So previous days, craniotomy they used to do if the fetus is dead. So even nowadays, craniotomy is the only destructive surgery which is permitted in modern obstetrics. That also, if the obstetrician is well trained. So most of the days nowadays, the junior doctors, even the postgraduates or even the assistants would not have seen even a craniotomy scissors. So the art is long gone, doing craniotomy. So always do a C-section instead of causing all injuries to the mother. Even though the baby is dead, better to do a C-section in the interest of the mother. So transverse lie, shoulder presentation and transverse lie, again 0.5%, I've already told you. Longitudinal lie is more common. And this is at right angles to the long axis of the uterus, right? If it is oblique lies, usually they get converted either into breech or into vertex. We are only worried about transverse lie with a shoulder presentation, right? So the incidence is 0.5%. So here the denominator is acromion and spelling tappundile. So you call it as right acromio anterior, acromio posterior, left acromio anterior, posterior, transverse, and so on. So most common is in acromio anterior, right or left. So causes are the same for any congenital abdomen, any malpresentation. Always think of all these causes, particularly in a persistent transverse lie shoulder presentations and persistent malpresentation. Always think of uterine abnormalities. So the patient says first time also the baby was presenting transversely, first time also the patient was presenting as breech. Always think of congenital uterine anomalies. Recurrent malpresentations, always think of uterine abnormalities, Mullerian abnormalities. Per abdomen, uterus will be asymmetrically enlarged, transversely more enlarged because it's a transverse line. Fundal height will be less than the period of amenorrhea because the uterus is transversely stretched. So this is one of the causes for where the fundal height is less than the period of gestation, other than IUGR, oligohydramnias, wrong dates. Okay. Congenital anomalies of the baby, all those things. So when fundal grip, when you see, you don't find any fetal pole. It is so fundal grip and the pelvic grip, both grips, you find that there is no fetal pole. So no fetal pole in the fundal grip. Lower pole will be empty on the pelvic grip, which immediately you should think that there is no presenting part. When you try to move either the head or the breech in the lower pole of the uterus, you don't find any presenting part. So that immediately it should struck to your mind that this may be a transverse lie. Then lateral grip, you will find head on the one side and the podalic pole on the other side. So So it is only the lateral grip which will tell you that this may be a transverse lie with shoulder presentation. Head will be found on the one side, lateral grip, and buttocks will be felt on the other side. So fetal heart sounds may be found at the level of the, not below, at the level of the umbilicus. Then transverse lie also shoulder presentation. There is no normal mechanism of labor. Unless it's a dead baby, it can undergo what is known as birth corpora conduplicata, where it gets completely compressed because of the uterine action. And then first the buttocks will be born, and then the head and the legs will be born. That is a doubled up fetus. So such things are very, very rare. So pelvic examination during labor, you will find that the premature rupture of membranes or the bag of membranes are not well fitting. Shoulder can be identified. And in these cases, whenever the membranes rupture, the patients come late in labor, you already find a hand is coming out or a cord is coming out. So nowadays we are not taking any X-rays, so ultrasound is usually confirms the diagnosis, and you can even exclude the abnormalities or the features abnormalities of the. So this is the transverse lie. So if you do a abdominal examination, fundal grip, you won't find anything, right? This has got an uterine anomaly also. See. And then you do a pelvic, because this lady is in labor, probably you may feel this part. But if she is not in labor, you find everything is empty here. So this woman is in labor, but the membranes have ruptured, and then the hand has come out, hand prolapse. So this is known as a neglected shoulder presentation. That means this woman was not diagnosed during the antenatal period or in the early labor and was not taken up immediately for a C-section. So you have allowed this woman to progress into labor. So cervix has dilated, membranes have ruptured, and then the hand has come out. This is referred to as a neglected shoulder presentation with a hand prolapse. Right. So if you want to know which side, which hand is this, you have to give a shake hand to this baby and see whether it is a left hand or the right hand. So that only tells you whether the dorsum is on the right side or on the left side. So here actually the positions are dorso-anterior, dorso-posterior, dorso-superior and dorso-inferior. Instead of having an anterior, transverse and posterior, we have dorso-superior, dorso-inferior, dorso-anterior and dorso so there is no normal mechanism of action. So you want to know, you have to give a shake hand to the baby. Right. So this is birth corpora conduplicata. This is what I have told you. Where the buttocks of the baby will be born first. Sometime because the hand has already prolapsed out, so this hand has come out. And then the head and the feet both will come together. They will be delivered together. This will happen in extremely preterm babies and in IUD babies. Because of the uterine contraction, it's a doubled up fetus. So it is very, very rare, which is referred to as birth corpora conduplicata. Favorable, favorable. So this is always early rupture of membranes, cord prolapse, fetal death, intrauterine infections, post cervical dilatation, then goes into obstructed labor. Bandle string is pathognomonic of obstructed labor, right? So always, and maternal distress, fetal distress or death and maternal distress. If you don't diagnose at that time also, it may result even in the maternal death. So undiagnosed shoulder presentation may lead to even death, obstructed labor, rupture uterus and death of the mother also. So even if the baby is dead, nowadays it is always better to do a C-section. Previous days they used to do what is known as spondylotomy, that is depending upon the whichever part of the baby is accessible. If the spine is accessible, you can do a spondylotomy, break up the spine. Or if the hand has already prolapsed, you give traction onto that hand until the neck is visible, and then you can do a decapitation can be done, deliver the baby first and then deliver the head. But those things are of only confined to the books nowadays. So neglected shoulder presentation, baby dead, mother is in obstructed labor with bandage ring, with all signs of maternal distress, always abdominal delivery in the interest of the mother. At least we have to save the mother instead of doing all those. Then if it is dorso-posterior, they used to do even evisceration. Dorso-posterior means back is towards the vertebral column and abdomen is accessible to us. So in such cases, they used to do what is known as evisceration. That means split open the abdomen, remove all the viscera. So that they're all very ghastly. Even if you think of it, you get nauseated. Okay. So we are not doing all those destructive surgeries nowadays. Okay. Thank you for your patient hearing. Bye. All the best. Eat well, read well, sleep well.